morning. Can you hear me?
Yes.
Okay.
Morning.
I know there's a lot of internet outages this morning. So we'll just see what happens this morning. First, are there any questions?
No, but I do have just something to tell you. I just have a doctor's appointment at 11:30, so okay.
No, I understand. That's fine.
Thank you.
Welcome.
So I'd probably be. I'll end them, like I'll leave at 11:30, and
Okay.
then. All right, thank you.
Yeah, I understand.
Thank you.
Of course. All right, we'll just see how many people show up. I know that Comcast is having internet issues. I had internet issues earlier, so I'm glad it's working out now. Let's see here. Sorry, bear with me just for a second here. Okay. If you don't give me 1 second, my notebook where I write down where we're at every time. It's not here all of a sudden. Where did I put it? Oh, there it is. Okay. Okay, come here, you. Okay. So we will finish chapter 13 today and start chapter 14. As soon as chapter 14 is done, which it'll probably take us about today and next Tuesday, as soon as we're done with it, the second exam is going to open. And it will cover chapter 7, 12, 13, and 14. Remember that your first case study is due on the 10th of this week. So it'll be due tomorrow night at midnight.
Do you care if so like I'm gonna do my case study at work, like I have it done, but I just need to draw the one part of it. Do you care if I like scan everything in and do an email and then send it to you?
I would prefer that you submit it online.
Yes.
So can you submit it in the Dropbox still?
I would believe so. I haven't tried to submit anything yet. I just am really worried about the drawings more.
I understand. It's better for me, and it'll keep me more organized if you're able to submit it in that Dropbox.
Okay.
Because then I don't struggle if I have everyone's submissions in one place, I'm less likely to lose them.
Okay.
And I'm yet to lose one, but I could see it happening. Also, when you scan it, make sure that you submit them. I need them submitted as either a Word, a PDF, or a JPEG. People like to submit things to me as Google Pages and Google Docs, and I can't open them. And the only way for me to open them is to pay for it. And I'm not willing to do that right now. And so as long as you can submit them there, if for some reason you can't, if something happens and you can't submit them there, let me know. We'll figure out something from there. Okay, Miranda?
Yes.
You will have another case study. It will be over, it'll be something to probably most likely to do with the spinal cord and the brain. And then you will have one more over muscles. I'm trying really hard to make sure that it's all material that it's all material that we have covered. So if you have questions, do me a favor and bring them up. Lab is usually easiest because we're not behind in lab, we're behind in lecture.
I do have a question. Which week is the Dropbox for the case study under?
It's actually under Dropbox right here. It's not under a specific week. Do you see this?
Yes, I see it. Okay.
Yeah, so if you go in here, it's right here. You got it, Miranda?
Yes, ma'am.
Okay. Let's so we were right here. So each track, actually, let me enlarge this. Each track so we have different spinal tracts. Remember, spinal tracts are essentially bundles of axon fibers that are running up and down the spinal cord. Sorry, not axon, myelinated axon fibers. We have ascending tracts that conduct sensory nerve impulses up the spinal cord toward the brain. And we have descending efferent tracts that are conducting motor nerve impulses down the spinal cord from the brain. Each track is going to carry specific information, types of information from one location to another. For example, if you want to carry painful information from the spinal cord to the tract, you use one particular tract, the spinothalamic tract. Well, if you want to carry voluntary movement commands from the brain to the spinal cord, you use a lateral corticospinal tract. I'm trying to think just how many tracts there are. I don't think there's more than 3 or 4 that you're being held responsible for to know. If you look in the book, there are a lot more. Just know the ones that we're discussing in the PowerPoint. Some tracts undergo decussation, which means that they're crossing the midline so that the brain is going to sense and control the contralateral side of the body. These tracts are the ones that are going to decussate are going to be ones that are contralateral, meaning that the origin and the destination are on opposite sides of the body. If tracts do not decussate, they are ipsilateral, meaning the origin and the destination are on the same side of the body. So not all, some decussate, some do not. So ascending tracts, and remember that this one, a specific type of ascending tract is the spinothalamic tract. Ascending tracts are sensory signals that are going to travel from across three different neurons from the origin, meaning the receptor out in the peripheral nervous system or the viscera. Peripheral nervous system is also the viscera. So they're going to move from the receptors out in the peripheral nervous system, the signals, via first order neurons, second order neurons, and third order neurons. The first order neurons are going to detect stimulus and transmit them to the brain, spinal cord, or the brain stem. Second order neurons are going to continue from the thalamus and the upper end of the brain stem from the second order neurons and out. I'm not saying this right. The receptors are the first order neurons. They're going to transmit the signal from the spinal cord or the brain stem. Second order neurons are going to continue from the brain stem or the spinal cord, somewhere within the brain stem or the spinal cord, and transmit those signals to the thalamus. The third order neurons are going to carry the signal the rest of the way from the sensory region in the thalamus, from the thalamus to the sensory region in the cerebral cortex. So first order from the signal from the spinal cord, the peripheral nervous system to within the spinal cord or the brain stem. The second order neuron is going to carry it from the spinal cord and or brain stem to the thalamus. The third order neurons are going to carry that signal from the thalamus to the sensory regions in the cerebral cortex. Is that clear, the relationship here? So some of them may use all three of those neurons. Some may not. It depends on what it is. Is that clear? One of the ascending tracts is the posterior funiculus. And this involves the gracili and cuneate fasciculi. They just conveyed sensory information with regards to discriminative touch, light pressure, and conscious proprioception. The gracili fasciculus, lots of interesting words here. Gracili fasciculus is going to convey the information from the sacral lumbar areas of your brain, of your body to your brain. So this is gracili fasciculus, it conveys information about the discriminative touch, light pressure, and conscious proprioception. We'll talk about proprioception in 1 second here. Cuneate fasciculus is going to carry the same sensory information, the discriminative touch, light pressure, and conscious proprioception, from the thoracic and cervical regions, including your arms, to your brain. So one carries sensory information about the lower part of the body, the gracili fasciculus. The cuneate fasciculus is going to carry sensory information from the upper thoracic cervical part of your body. Both of these fasciculi are composed of first-order neurons. So they're going, if you remember from the last slide, they're going from the receptor into the spinal cord or brain stem. You have questions for me? So think of this one thing that might help to think of this is think of this as a roadmap. We're talking about the pathways, the roads that lead to certain areas. And in the next chapter, we'll specifically spend more time talking about the thalamus and how it relates to the brainstem and so forth, and the cerebral cortex. But right now, we're just looking at a pathway of roads. So when we go over chapter 14, look back on some of these ascending tracks, and it'll become clearer to you how they're moving. So light touch, pressure, and proprioceptive senses that are carried out by muscle spindles and other sensory receptors are carried through these pathways. These gracilian cuneate fasciculi. Now, what's proprioception? That was probably the biggest word outside of the names of the fasciculi there. And if my teaching assistant was here, my mom, and she's not here. My dog is a teaching assistant, but she's not very good for this one. I would have her help me with this proprioception concept. But what this means is that you can close your eyes, close your eyes, and you can move your joints. I can move my joints wherever I want to do it. And even with my eyes closed, because there's receptors in my joints, the muscle spindles, I know where all my joints are with my eyes closed in space. If someone else were here and they moved my joints, I would still know where all my joints are. I would know whether my hands were raised up, whether they were extended, whether they were flexed at the elbows with my eyes closed. So this is a matter of knowing where all your joints are in space. It's kind of a big deal if you think about it. This ability to be able to be aware of all your joints, even when you're not looking at them. You can try it with somebody. If you have someone at your house, try it with them. And what you do is you have them close their eyes and you move their joints around. And then ask them to tell you where they're at. they can tell you exactly where they're at. Kind of an interesting thing to think about. So the gracilli and the cuniculate, no, it wasn't cuniculate, cuneate, gracilli and cuneate fasciculi were in the posterior funiculi. The spinal thalamic tract is made of second order neuron fibers. And it's going to transmit signals with regards to pain, warmth, coolness, tickling, itching, and deep pressure. Due to the crossing, remember that we call that decussation. Due to the crossing of the second order neurons, remember this is going to happen in the spinal cord. They're going to cross. Due to the crossing of the second order neurons, so these signals from the spinal thalamic tract are going to be sent to the contralateral side of the cerebral hemisphere. If you've ever heard that pain is a sense of tickling, let me put it in another word. Tickling is a sense of pain. Itching is a sense of pain. If they tell you that an injury that you have is itching, and they've told you not to itch it, because itching is a form of pain. So temperature, pain, and deep pressure are all working through the spinal thalamic tract. And these are this tract is going to undergo decussation. So remember what the funiculi are. Those are the axons of the myelinated axon tract bundles. So the gracilli and cuneate fasciculi are in the posterior funiculi. The spinal thalamic tract is in the anterior and lateral funiculi. And this one is going to decussate. The signals are going to be sent to the contralateral side of the cerebral hemisphere. Questions about the ascending tracts? So moving on to the descending tracts. Signals that are conducted here are motor signals that are going to be conducted down from the brainstem and spinal cord. Rather than having first order, second order, and third order neurons, here we have upper motor neurons and lower motor neurons. Upper and lower. Upper motor neurons are going to originate in the cerebral cortex or brainstem and terminate on a lower motor neuron. So they can originate up in the upper cerebral cortex or the brainstem. And they're going to terminate on a lower motor neuron, which is in the brainstem or the spinal cord. They're going to, let me not say terminate, they're going to synapse. I think that's a better word to use here, because we know what a synapse is. They're going to synapse anytime we talk about termination. It doesn't talk about termination here. But rather than say that they terminate because that means that the signal's lost, that isn't the case here. It's going to synapse onto a lower motor neuron. The lower motor neuron soma is in the brainstem or the spinal cord. The axon of that lower motor neuron is going to exit out the anterior horn of the spinal cord and go out to muscles and other target organs. Remember that sensory information comes in the dorsal horn. Anterior and motor information leaves through the anterior horn. So the axon of the lower motor neuron is going to lead out through the anterior horn. The one descending tract that you need to know, the lateral corticospinal tract, is going to conduct nerve impulses from the cerebral cortex of the brain to the spinal cord for voluntary movement of skeletal muscles. So this is your somatic nervous system, your voluntary movement. If you remember, we talked about that branch of the somatic nervous system at the beginning of chapter 12. This is your somatic nervous system. If your brain decides that it wants your legs to move, it sends this voluntary information command from the brain down to the region of the spinal cord that's responsible for leg movements using this particular tract. Which state of the following statements is true concerning the spinal thalamic tract? The spinal thalamic tract terminates in the spinal cord. The spinal thalamic tract begins in the thymus of the brain. The spinal thalamic tract is found in the gray matter of the spinal cord. The spinal thalamic tract carries motor information down the spinal cord, or the spinal cord is composed of multiple axons carrying information in the spinal cord. I told you not to think of that word as being terminates, but I think that's probably still a good way to refer to it because it's where that particular neuron tract ends and it synapses on something else. But what would you say? Is a spinal thalamic tract, is it sensory or motor?
Sensory.
It's sensory. So it can't be D or E, right? Actually, it could be E, but it can't be D. Is it white or gray matter? What are tracts?
White.
So it also can't be C. Okay. So we know that it's not those two. The spinal thalamic tract, would it begin in the thymus? Remember, it was
Second order.
second order neurons. So where would it probably begin?
Thalamus.
I think you're right, it's B. So the spinal thalamic tract is going to begin in the thymus of the brain. So sometimes answer true and false questions based on the rule of elimination. What isn't correct, and go from there. Amyotrophic lateral sclerosis, or Lou Gehrig's disease. Are you familiar with this person? This was one growing up, actually not growing up, but up until he's been someone that I've admired for a while. Does anyone know who he is?
Stephen Hawkins.
That's Stephen Hawking. So he died, I think, about 2 years ago. And he was diagnosed with ALS when he was 22, 21, 22, somewhere in there, and was told that he had 3 years to live. And you can see he obviously didn't die at 24. We learned with his adventures and other people's adventures, we learned that there's early onset ALS and there's late onset ALS. Late onset ALS tends to
oh my God, my stupid video's on. I can't.
We liked your picture.
I can't. I'm having so many problems this morning.
I'm sorry. I understand that.
I had to log on to a new laptop.
Okay.
Okay, sorry. Go ahead.
No, you're all right. So ALS is characterized by progressive degeneration of motor neurons in the spinal cord, brain, and motor cerebral cortex. I should maybe mention what the cerebral cortex is. The cerebral cortex, and I'm sorry, I'm going to skip back a little bit here. The cerebral cortex is the outer lining here of the cerebrum, which is this area. So anytime we talk about a cortex, it's the outer surface. So with that in mind, ALS is characterized by progressive degeneration of the motor neurons. So if you think that's your lateral corticospinal tract. The neurotransmitter, from what they understand, the neurotransmitter glutamate increases. And it's an excitatory neurotransmitter. Because it continues to increase and it doesn't slow down or stop, this gradual neurotoxicity or excitotoxicity occurs with an accompanying rise in calcium levels. You remember what calcium is. Calcium is what allows for the synaptic vesicles to be exocytosed that contain the neurotransmitter in the axon terminal. So it's what allows for secretion of the neurotransmitter. So there's gradual neurotoxicity, which results in a normal increased rise of calcium, which ultimately, because the levels get so high, ultimately is going to damage the dendrites and destroy the dendrites. What were the dendrites? Do you remember?
They were the things that come out from a neuron to receive the sensory.
Right. So if you slowly lose those incoming signal areas, you slowly lose what's going to allow you to get new information. you can see why your motor neurons are no longer going to function, right? If you're no longer able to receive signals with regards to voluntary movement, or I don't know if it's specifically only the lateral cortical spinal tract. We have other motor movements that don't involve voluntary means. But if you think about it, ultimately you lose all abilities to move your motor neurons because you lose the dendrites. So that is what we know about ALS right now. You see how your neat stuff that you're learning in this class, even though a lot of it's kind of overwhelming at times, you're learning some neat stuff that you can apply to new situations and to things that you've already heard about and already know about. The spinal cord communicates with the rest of the body by way of spinal nerves. The nerve, remember we called them these axon, we call in the central nervous system, we call bundles of axons tracts. In the peripheral nervous system, we call them bundles of axons nerves. If you remember that from chapter 12. So the nerve is a cord-like organ composed of numerous nerve fibers bound together by connective tissue. The epineurium is on the outer edge of the nerve fiber or of the nerve. The perineurium is around each bundles of fasciculi. Remember that those are bundles of axons. Each one of these nerves tend to be mixed nerves containing both afferent sensory and efferent fibers. So in my guess, looking at this, is that each one of these fasciculi, you'll see we have more than one here. So we have 1, 2, 3, 4, 5, 6, 7, 8. Each of these fasciculi carry specifically sensory or motor. This one maybe carries sensory, this one carries motor, this one carries sensory, this one carries motor fibers. And they're all bundles. And they're bundled together. That's why it's a mixed nerve. So epineurium on the outer edge of the outer covering of the whole entire bundle of fasciculi. Perineurium surrounding each individual fasciculi. And endoneurium on the outer edge of the myelinated neurons. So the endoneurium is a loose connective tissue external to the neural lemma around each axon. The perineurium are layers of surrounding squamous cells that wrap the fasciculus, bundles of nerve fibers. The epineurium is a dense, irregular connective tissue that's going to wrap around the entire nerve. So looking at a cross section here, epineurum on the most outer edge, around each fasciculi, around each fascicle is the perineurium. And surrounding each myelinated axon, right outside of the neural lemma, is the endoneurium. Remember that relationship. Epi is always completely on the top. Peri is surrounding something. Endoneurium is the most internal layer. When you go in, we'll talk about it again when we talk about muscle. You'll see it when we talk about the heart. We always, epi most outer, peri is a surrounding layer. Endo is the most inner layer. So the nerve fibers in the peripheral nervous system are surrounded by Schwann cells. Remember what those are one of the neuroglia of the peripheral nervous system that form the neural lemma and myelin sheath around the axon. Blood vessels also penetrate the connective tissue coverings to provide a plentiful blood supply to service the high metabolic activities of nerves and neurons. One thing that they're learning more and more, I spent a lot of time in my graduate school studies studying peripheral neuropathy and how it worked. And one thing that I gained from it was that much of peripheral neuropathy occurs, or at least a good part of it, and probably more than we realize, occurs because of the loss of the blood vessels in this area. Certain drugs, certain inflammation issues, type 2 diabetes, certain cancer drugs work to prevent blood vessels from growing, and blood vessels are constantly needing to recover and heal. If you can imagine, you've always got fluid running through a cell-lined surface. That's what a blood vessel is. It's got blood always running through it. Blood vessels are constantly under attack. And so they're constantly needing to be healed. Well, if you treat someone with drugs, or you're going through a chronic inflammation stage where blood vessel synthesis and buildup may not be at the same level it needs to be, at other times it's not working at its optimal level, you're going to see a loss of blood vessels. And peripheral neuropathy results from the loss of the blood vessels in the peripheral nerves. There's been some studies out there that show that if you can regenerate those blood vessels, you can reverse the neuropathy. And if you think neuropathy is not being able to feel things or tingling, starts with a tingling and leads to a not being able to feel things. So interesting stuff. So different type of nerves, just like we saw before, sensory afferent nerves carry signals from sensory receptors to the central nervous system. Motor efferent nerves carry signals from the central nervous system to the muscles and glands. And remember which one's dorsal horn is, it brings in sensory information. anterior horn is where motor neurons exit. They merge together to form a spinal nerve, just like we saw here. They merge together. So mixed nerves consist of both afferent and efferent fibers. Both sensory and motor fibers can be described as either being somatic or visceral, general or special. So afferent fibers carry sensory signals from receptors to the central nervous system. Efferent fibers carry motor signals from the central nervous system to effector organs like muscles and glands. Somatic fibers are going to innervate the skin, the skeletal muscle, the bones, and joints. Visceral fibers are going to innervate blood vessels, glands, and viscera. General fibers, always think viscera as meaning organs, internal things. Somatic is anything related back to muscles a lot of times. So skin, skeletal muscles, bones, and joints. General fibers are going to innervate widespread organs such as muscles, skins, glands, viscera, and blood vessels. Special fibers are going to do your special senses, your hearing, your taste, your sight, your vision. Muscles of chewing, swallowing, and facial expression. A ganglion, we have a posterior or dorsal root ganglion right here. A ganglion is a cluster of neurosomas outside of the central nervous system. So among the neurosomas, remember neurosomas are cell bodies of the neurons. So a ganglion is a cluster of cell bodies. Among the neurosomas are bundles of nerve fibers leading into and out of the ganglion. Here are muscle fibers. And here's some neurosomes. The posterior root ganglion is what's associated with the spinal nerves. Each spinal nerve is formed from two roots. We have the posterior root, which contains the sensory input coming into the dorsal horn. The dorsal root ganglion contains the somas, the cell bodies of the sensory neurons, carrying signals to the spinal cord. And it breaks off into 6 to 8 rootlets, which enter the posterior horn of the spinal cord, or the dorsal horn. Remember that dorsal and posterior mean the same thing. The anterior ventral root is the motor output, where 6 to 8 rootlets are going to leave the spinal cord and converge to form the anterior root. Questions for me? posterior ramus. Looking here, dorsal ramus, we also call it the dorsal ramus. Posterior ramus is a branch of each spinal nerve that's going to innervate certain parts of the skin, muscles of the neck, and deep muscles of the back. So it is right here. Not like this. Here's the spinal nerve. Here's the posterior ramus. Remember, ramus is like an arm or an extension. The anterior ramus in the thoracic region is going to give rise to intercostal nerves. If you think costal meaning ribs on the rib cage. So intercostal nerves are the nerves in between the ribs. We're going to innervate the rib cage. I showed you this picture last week in lab, but I decided to add them to this PowerPoint because I think sometimes we get a lot of diagrams, but they don't tend to do, but they don't do it justice sometimes. It's a lot more fun to look at what it really looks like sometimes, at least for me. So here's a cross section through the spinal cord. This is the anterior side. This is the posterior side. So these are the anterior horns. These are the dorsal horns. Here's the anterior rami. Here's the posterior rami. Remember, anterior rami, this is always motor coming out the anterior horn. Sensory information coming in via the posterior rami. Right about right in here would be where our rootlets would be. Here's our epidural space. Here's our dura mater right underneath it. And right underneath it is the arachnoid mater. And this black space in here is a subarachnoid space. Questions? And remember that the pia mater is right on top of the spinal cord. So another picture, as we talked about the rootlets, this is a much more, this is what do you call it? A transverse section. This is looking at the tissue when everything has been dissected, what a frontal, maybe a frontal section, kind of. So here's the spinal cord. Here's the rootlets. Here's the dorsal root ganglion. And you follow it out. Here are the two different rami. Actually, it might be that one back there. It's not labeled, obviously, here. It might be that one back there. But here's another picture. So here's the spinal cord. Here's the rootlets. and it merges together here. Forms, here's the dorsal root ganglion. Remember, that contains the cell bodies of the sensory afferent nerves. Spinal nerve, the dorsal ganglion, the dorsal ramus, I don't know why I said ganglion, dorsal ramus or posterior ramus, and the ventral anterior ramus. Questions? So the anterior ramus, remember the anterior ramus in the thoracic region is going to give rise to the nerves of the intercostal nerves. In regions other than the thoracic region, it's going to enter into plexuses, from which peripheral nerves will arise that will innervate ventral and lateral body surfaces, structures in the body wall, and limbs. The rami communicantes this little spot right here. Oh, here's our posterior ramus, here's our anterior ramus. The rami communicantes is composed of the branches of each spinal nerve that contain axons related to the autonomic nervous system. Remember, the involuntary nervous system, consisting of pairs of rami, one white ramus and one gray ramus. Here's the rami communicantes. It's coming off of the sympathetic chain ganglion, which we'll spend a lot of time talking about. It only runs down this thoracic region from T1 to L2. And we'll talk a lot about it when we talk about the autonomic nervous system. The meningeal branch of each spinal nerve is a branch of the spinal nerve that serves the vertebrae, the vertebral ligaments, the blood vessels of the spinal cord, and the meninges. A pinched nerve occurs when too much pressure is applied to a nerve by surrounding tissues such as bones, cartilage, muscles, or tendons. The pressure disrupts the nerve's functioning, causing pain, tingling, numbness, or weakness. An example of this would be sciatica, which we'll talk about later, when the sciatic nerve gets pinched. Another way is a herniated disc. Well, that's what results in sciatica, causing pain that radiates down the back of your leg. A pinched median nerve in your wrist can lead to numbness and weakness in your hand and fingers, which is what carpal tunnel syndrome is. My dad, who is my computer expert, is a computer guru. He knows everything about computers. And he has had surgery on his carpal tunnel 3 times so far. What it is there's a tendon sheath that runs around your wrist. And when they go into it's remember, because it's tendon, it's tight, it's restrictive. It kind of holds all your ligaments and muscles of your wrist together in one spot with your carpal bones. So because it's tight, I mean, it's a supportive protective function to have it be tight and restraining. However, when you're constantly doing small movements with your wrist, you've inflamed the median nerve. And so it enlarges. But it has really nowhere to go because it runs underneath this sheath. And so the only way to alleviate some of the pinching of that nerve is to make small cuts in this sheath to give that nerve some more space. So dorsal roots along dorsal roots along the spinal cord carry what kind of neurons? While the dorsal rami carry what neurons? What do the dorsal roots carry? Someone tell me, what do the dorsal roots carry? You guys go back and look, or I'm going to call on a name. Someone tell me.
Sensory signals.
So they carry sensory signals. What about the dorsal rami? Looking back here. What do they carry? Actually, let's come back a little bit further. They're going to be mixed because they're going to carry both motor and sensory. So we're going to have sensory with mixed. So the ventral anterior rami of the spinal nerves form the networks of nerves called plexuses. The intercostal or thoracic nerves are not going to enter into plexuses. You're going to see we have a cervical plexus here, a brachial plexus here, a lumbar plexus here, sacral plexus, and a coccygeal plexus. We skip this whole area right here. So the intercostal or thoracic nerves of the anterior rami are not going to enter into plexuses, but they're going to innervate the structures they supply in the intercostal spaces. The cervical plexuses serves the skin, muscles of head, neck, upper part of shoulders, and diaphragm. The phrenic nerve is probably the major nerve that you need to remember that arises off the cervical plexus. Why is it so important? It innervates the diaphragm. This is your major muscle involved in allowing you to breathe. It comes off of C3, so spinal root 3, C3, spinal nerve C4, spinal nerve C5. So a break above C1 or C2 is going to cause you not to be able to breathe on your own. If C3 through C4 through C5 are intact, you will still be able to breathe on your own. We're looking at a model of cervical plexus, the phrenic nerve coming off. Injuries to the phrenic nerve, sometimes, depending on how badly the injury has been, can result in can be partially compensated for by a phrenic nerve stimulator or pacemaker system that stimulates the phrenic nerve. This will provide for ventilation support for patients with chronic respiratory insufficiency whose diaphragm and lungs and phrenic nerves have some residual function. These can be used in quadriplegia and congenital central hypoventilation syndrome, diaphragm paralysis, and brainstem stroke and brain injury and brain tumor issues. So instead of a ventilator, which is forcing air into the lungs, a phrenic pacemaker is going to enable the diaphragm to contract and allow the patient to inhale more naturally. Questions? Brachial plexus is divided into roots, trunks, divisions. We have an anterior division and a posterior division, cords, and nerves. The nerves from the brachial plexus are going to supply, brachial meaning arm, so they're going to supply the neck, the shoulders, and the upper limbs. Major nerves coming off the brachial plexus: the musculocutaneous nerve, axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. Looking at a model. Injuries to the median nerve. Erb's palsy is a paralysis of the arm that often occurs as an infant's head and neck are pulled toward the same side of the body as the shoulders pass through the birth canal during delivery. So it's a major strain to the brachial plexus. Oh, it would be more like this. Okay. A similar injury can be observed at any age, including adults, following a traumatic fall or other trauma whereby the nerves of the plexus are violently stretched. Injury to this nerve is also what's resulting in carpal tunnel, if you remember from before. It's the median nerve. Seen in people who perform repetitive motions with their hand and wrist. So using a mouse on a computer. ulnar nerve. You want to know this, a good way to test your ulnar nerve, and everyone do this with me. So I'm going to stop sharing just for a second. Take right here, take your elbow and smash it on the surface. Smash it really hard.
No thanks.
Rachel, I don't get it. You got to live a little adventurously. Maybe don't do it. Rachel's like, someone has to be the voice of logic here.
I do it on accident too many times.
All right, don't do that. What I want you to do instead is, rather than smashing it in a very violent manner, here's your medial malleolus. Here's your lateral malleolus. Put pressure right there in between them. You got to push fairly hard. Don't do it on someone else unless they tell you it's okay. Tell me where you feel the tingling.
Up my arm.
What part of your arm?
Towards my hand.
What part of your hand?
My pinky.
It's your pinky, right? So your ulnar nerve is right there. It's the most exposed nerve you have. And so when you bang it against something, what you're doing is you're essentially crushing that nerve up against the bone. And what you get is that tingling pinch effect all the way up your hand, because anywhere that that nerve travels, it's going to innervate. Wherever that nerve travels, if it moves through a muscle, it's going to innervate that muscle. If it moves by the skin in that area, it's going to innervate that skin. One reason we like to know the routes of nerves is because anywhere that it travels, it innervates. And when you slam your elbow, you pinch that nerve up against the bone. Damage to this nerve can result in abnormal sensations in the fingers, inability to abduct or adduct the little and ring fingers. The lumbar plexus, L1 through L4, supplies the anterior lateral abdominal wall, the external genitalia, and part of the lower limbs. The femoral nerve is the largest nerve of this plexus. Damage to the femoral nerve can result in inability to extend the leg, loss of sensation in the skin over the anterior medial aspect of the thigh. So here's the femoral nerve. Plus, one of the last plexuses. The coccygeal plexus only has one nerve coming off it, so we don't really tend to talk about it a lot. Sacral plexus supplies the buttocks, the peritoneum, and the part of the lower limbs. It gives rise to the sciatic nerve. Damage to the sciatic nerve is going to result in sciatica, which can occur due to a herniated disc, a dislocated hip, or pressure from the uterus during pregnancy. You just get it gets pinched. Sciatic nerve. If irritated, this nerve will cause hiccups. What do you think? If irritated, this nerve will cause hiccups.
Could it be C?
Why do you say C?
Because it's with the diaphragm and the hiccups is with the breathing type. Yes.
That's exactly right. So a dermatome is specific areas of the skin that convey sensory input to the spinal cord. A dermatome map is a diagram of the cutaneous regions innervated by each spinal nerve. So each spinal nerve innervates a certain patch of skin. And that patch of skin is a dermatome. A map shows that shows the body and where each spinal nerve, what patches are innervated by each spinal nerve. Dermatomes can overlap in their edges by as much as 50%. So it may be necessary to anesthetize 3 spinal nerves in order to produce a loss of sensation in one dermatome. Knowing which spinal cord segments supply each dermatome makes it possible to locate a damaged region of the spinal cord. Where do you lose feeling along your skin? Well, it's got to be that, maybe that spinal nerve or that spinal nerve. It's going to allow for, what's the word for it? Eliminate what spinal nerves are not involved. Shingles is an acute infection of the peripheral nervous system by the herpes zoster virus. Right now we have a shingles vaccine, which is fairly new. I think it's only been out about maybe 5-10 years, maybe less than that.
I believe if I remember correctly, it's only 85% correct or 85% effective.
Well, 85% is better than a lot of things.
Than none.
If you think your flu vaccine is usually about 60 to 70%. Most, yeah, 85% is actually fairly effective. After one gets better from the chickenpox caused by a Varicella zoster virus, the virus will remain dormant in the dorsal root ganglia. I remember where that is. So that's where the cell bodies of your sensory nerves are. In some people, it stays dormant forever and is kept in check by the immune system. However, if the immune system gets compromised, if you get stressed, the virus can travel along the sensory nerve fibers via the axonal transport. Remember, that's from the cell body anterograde, so from the cell body to the axon terminal, and cause shingles. This is characterized by a painful trail of skin discoloration and fluid-filled nerves. So the physicians can determine can pinpoint which nerves are affected by which dermatomes are affected. Guys, I'm going to keep going. So bear with me here. I know it's a long 3 hours, but I want to get started on the next chapter and I want to get a good start on it. So please be patient with me here. Nature of reflexes. Reflexes are quick, involuntary stereotyped reactions of glands or muscle to stimulation. Four basic characteristics of reflexes. They require stimulation. They're not spontaneous actions, but always responses to sensory input. Reflexes are quick. They involve few, if any, interneurons and minimum synaptic delay. So majority of them, many of them are monosynaptic. Remember that from lab. Reflexes are involuntary, meaning they occur without intent and are difficult to suppress. You can do it, it just takes a lot of work. I'm pretty reflexive when it comes to fainting. And I've learned what the signs are. And so I usually am able to pull myself out of it, but sometimes it takes a lot of work. Reflexes are stereotyped. They occur essentially the same every time. A reflex arc works the same way a feedback loop works. We have a receptor that responds to a stimulus by producing a generator or receptor potential. Remember that membrane potential. A sensory neuron, which has an axon that conducts the impulses from the receptor to the integrating center. An integrating center, one or more regions within the central nervous system that relay impulses from the sensory to the motor neurons. A motor efferent nerve fiber, and an effector, a muscle or gland that responds to the impulse. So here's your receptor, here's your afferent signal, here's your integration center, here's your efferent signal, here's your effector. Remember this from a feedback loop. So a reflex is a feedback loop. Testing somatic reflexes. So testing reflexes involving skeletal muscles aids in diagnosing many diseases. Monosynaptic reflexes are reflex arcs that skip the interneuron. So it involves a receptor, a sensory neuron, a motor neuron, and an effector. It's where a monosynaptic, meaning that the sensory neuron is going to synapse directly on the motor neuron. You skip the middleman. Remember, mono means one, so means one synapse between the sensory and the motor neuron. Polysynaptic is reflex arcs that include the interneuron in between the receptor and the sensory neuron and the motor neuron and the effector. So this is where we include the middleman. Ipsilateral, remember that decussation? Ipsilateral, meaning that reflex arcs in which a stimulus that comes from the one side of the body and the response occurs on the same side. So they're not going to decussate. contralateral are going to decussate. Reflex arcs in which a stimulus comes from one side of the body and the response occurs on the opposite side of the body. A stretch reflex, or the patellar reflex, this is the one I showed you last week in class that my mom helped me with. When a muscle is stretched, it fights back and contracts. You use these to help maintain equilibrium and posture. So you tap the patellar ligament, it's the ligament right here. Tap the patellar ligament, which excites the nerve endings in the muscle spindles, the receptors in the muscles of the quadriceps femoris. The stretch signals travel to the spinal cord via an afferent primary fiber and then the dorsal root. The primary afferent neuron stimulates an alpha motor neuron in the spinal cord. The efferent signals in the alpha motor nerve fiber stimulate the quadriceps to contract, producing a knee jerk. Is this monosynaptic or polysynaptic?
Would it be poly?
Why do you say it's poly?
Because, I don't know, it's like a domino effect. So there's more than one thing working.
It's not. Let's put it this way. All reflex arcs are going to be domino effects. Some are going to involve an interneuron, a middleman. Some aren't. Does that help?
Sure.
Not really. Polysynaptic is a domino effect. You get a sensation, it stimulates, and then you get a motor neuron effector. Between that sensory and the motor, there's an interneuron. Monosynaptic is when the sensory neuron is going to synapse right on a motor neuron. And when we read through the steps of this, the primary afferent neuron is going to stimulate an alpha motor neuron in the spinal cord. There's no interneuron involved. The efferent signals are going to stimulate the quadriceps to contract, producing a knee jerk. At the same time, a branch of the afferent nerve fiber is going to stimulate an inhibitory motor neuron in the spinal cord that's going to relax the hamstrings. So that they don't contract when the quads is trying to contract. So they'll relax when the quads contract. A flexor withdrawal and cross extensor reflexes demonstrate an intersegmental. You remember how the spinal cord is segmented. So this reflex is going to involve multiple segments within the spinal cord. You step on a nail, or you step on a Lego. That's another really fun thing to step on barefoot. You step on a Lego. It triggers contraction of the flexors in the knee. That you of the foot that you just stepped on the Lego. And at the same time, it's going to cause relaxation of the extensors in that same leg, which is going to allow you to pick up your leg off the darn Lego. So that we kind of saw the same thing here. Relaxation of the hamstrings with contraction of the quads. That's the withdrawal flexor reflect. A crossed extensor reflex is going to occur at the same time so you don't fall over. It's going to involve contraction of the extensor muscles in the opposite limb. That's going to allow for maintaining balance by extending the other leg as this leg flexes. One thing you can look at here is this is always a contraction of one muscle while there's a relaxation of another muscle. Both of these in response to a stimuli. This flexor reflex uses an ipsilateral reflex arc, where stimulus and response occurs on the same side, where you get a contraction and a relaxation on the same side. Whereas a crossed extension reflex uses a contralateral reflex arc. The input and output are on the same leg. Or opposite legs, I'm so sorry. Opposite legs. This leg, you contract the flexors and inhibit the extensors up here. And so that you don't lose your balance when you lift your foot off the Lego, you're going to contract the extensors in the opposite leg. That contralateral reflex. So this is an intersegmental reflex, one in which the input and the output are going to occur at different levels. Pain in the foot causes contraction of abdominal muscles also. That's why it's intersegmental. You've noticed you worked out your abdominal muscles when you're working out your legs. Questions? So the flexor reflex is the same as a stretch reflex. One set of muscles is relaxed while another set contracts. The only major difference here, or the two major differences, is that the muscles in the opposite leg are going to get, the extensors are going to get contracted. They're going to relax here and contract here. And there's an intersegmental thing because the abdominal muscles contract also. Questions? Which best describes reciprocal innervation? You guys, an agonist is something that works with something else. An antagonist is working against it. So what would you say?
B, because it's relaxation at the same time as contraction.
Come up and look at this. Look at this. You see it? You're close, Aaron.
So it's the other way around.
It's the other way around.
Okay.
So it's going to be relaxation of an antagonist. Actually, it's going to be relaxation of an antagonist at the same time there's contraction of an agonist.
Well, yeah. So because they're happening at the same time.
Yeah. Yep. Exactly. Exactly. And then you recognize that you've been hurt. This is one of those things where Miranda didn't obviously would grab the wrong end of the curling iron. Same thing, except for what Miranda did, where she held on to it. That still makes me crazy. Where you grab the wrong end of a curling iron and you drop it, and then you recognize that you've been hurt. Almost the last slide here. The Babinski or plantar flexion is normal in adults if they flex and curl their big toe when the sole of their foot is stimulated. If their toes fan out when you do this, it indicates there's damage of the corticospinal tract. Babies up until about, a year will give you, their toes will fan out. They'll extend out their toes. In a normal, healthy adult, they will curl them in. I mean, if you've ever done this on yourself, it tickles. And so you tend to curl in your toes. But on a baby, they fan out. Remember that it's a myelination thing for babies with their central nervous system. Remember, very little of the central nervous system is myelinated right after birth. Last slide of this. Complete transection, complete severance of the spinal cord, immediate loss of the motor control below the level of the injury. If there's a danger above C4 and C3, you run into the threat of respiratory failure. Remember that it's C3 through C5 that innervate the diaphragm via the phrenic nerve. So a break in between C1 and C3 is going to result in a loss of breathing. Break in between C6 and C7 is going to put you in a wheelchair, but the ability to breathe will still be there. T10 to L1 is probably going to result in a walker with paralysis on one side of the body. And paresis is going to be, and L1 to L2 is going to be weakness in the limbs. So paraplegia is paralysis of both lower limbs. Quadriplegia is paralysis of all four limbs. Hemiplegia is paralysis of one side of the body. And paresis is partial paralysis or weakness of limbs. Questions for me? Let's start on chapter 14. So because we finished chapter 13 today, the chapter 13 quiz will be due next week, Wednesday night at midnight. I'm going to extend out the chapter 14 quiz. But the chapter 13 quiz will be due next week at Wednesday at midnight. The Smart Book assignment will be due at that same time. So I'll extend out this chapter 13 here. So it won't be due this week, it'll be due next week. So the brain and the cranial nerves. Chapter 14. So the brain is extremely complex. The body uses only about 3 pounds of tissue to simultaneously conduct and coordinate a variety of incredible processes. And this is a typo here, obviously. The brain's function is clinically associated with what it means to be dead or alive. All of these functions and many others occur within the 85 billion neurons and 10 to 50 trillion neuroglia that comprise the human brain. So approximately 3 pounds. Looking specifically at the very beginning here of human embryo brain development, as the human embryo develops, the neural tube, so we start as a tube, the neural tube is going to form 3 anterior bulges, the prosencephalon, the mesencephalon, and the rhombencephalon. Remember, cephalon always means brain. Let's see here. Cephalon. Cephalon always means head or brain. Let's say brain. Pros. Prosen. Actually, let's not say, we're going to say rather than just cephalon, we're going to say encephalon. Pros means a forerunner or the beginning, or the first beginning. Mesencephalon, meson means middle. And rhombencephalon, let's see, rhombo, I think that's what it was, means hind. And I'm going to say, rather than say mes here, I'm going to say mid. You'll understand why in a minute here, but this means hind or end or bottom. So the forebrain is the prosencephalon. It's going to develop into, so these three bulges are going to form three major brain vesicles. The first anterior bulge is going to be the prosencephalon, which is going to form the forebrain. The midbrain is going to form the mesencephalon. And the hindbrain is going to form from the rhombencephalon. Prosencephalon, forebrain. Mesencephalon, midbrain. Hindbrain is the rhombencephalon. Ultimately, the forebrain is going to become the prosencephalon is going to become the cerebrum. The mesencephalon is going to become the midbrain. And the brainstem and the hindbrain, which includes the cerebellum, is going to form from the hindbrain or the rhombencephalon. There's an encephalization. What this encephalization, meaning that the prosencephalon and the rhombencephalon, remember these are this one, are going to further divide to form 5 secondary vesicles. Prosencephalon is going to become the telencephalon, the optic vesicles, and the diencephalon. The rhombencephalon is going to become the metencephalon and the myelencephalon. And the midbrain is going to stay the mesencephalon. So we get these five, actually ultimately 6 different vesicles from 3 primary vesicles. Also the mesencephalon. Each of these vesicles, these are the forms that are going to be produced, or the structures that are going to be produced from each of these different vesicles. So the prosencephalon is going to form the cerebral hemispheres, the thalamus, the hypothalamus, and the epithalamus. With the telencephalon forming the cerebral hemispheres. And the diencephalon, the thalamus, the hypothalamus, and the epithalamus. The mesencephalon is going to form the midbrain structures, which is going to include the corpora quadrumina, the cerebral peduncles, cerebral aqueduct, and the substantia nigra. And we'll talk about all of these structures as we go through this chapter. The rhodoencephalon is going to, with becoming the metanocephalon, I think it's metanocephalon. And the myelencephalon, the metanocephalon is going to become the pons, part of the midbrain, and the cerebellum. And the myelencephalon is going to become the medulla oblongata, or part of which is part of the brainstem. So the telencephalon is going to become the cerebral hemispheres. During the first 2 to 3 months of embryonic development, there's this massive expansive outgrowth of the telencephalon, which causes the outer portion, the cortex. Remember, we talked about the cerebral cortex a little bit in the last chapter. Causes the outer portion, the cerebral cortex of the cerebrum, to extend over much of the rest of the brain. My mom's coming in, so bear with me here. It's going to extend over. Don't bark, don't bark, don't bark, don't bark, don't bark. You want to go get her? Go get her. So the telencephalon causes the outer portion of the cortex of the cerebrum to extend over and around much of the rest of the brain. So it's going to surround the rest of it. It's going to be a major expansion. The brain develops at an amazing rate during development, with as many as 50,000 neurons being added per second. Almost all of the neurons in the brain are present at birth that will ever be there. Questions first, or just keep going? So we talked about what the distinctions between white and gray matter. It's the same thing here. Gray matter has a dull color due to the fact that there's very little myelin there. It forms the outer surface layer over the cerebrum and the cerebellum. It's composed of neurosomas, dendrites, and synapses, just like it was in the spinal cord. And the gray matter includes the nuclei. Remember, those are the cell bodies. In this case, the nuclei are the cell bodies that are deep within the brain. The white matter, which is deep to the cortical gray matter, remember that this is the opposite. Remember, in the spinal cord, the gray matter is on the internal surface, the internal region. Here, the gray matter is on the outer region. So it's deep to the gray cortical matter and opposite to that observed in the spinal cord. It's pearly white because of the myelin. And it's composed of axonal tracts. So let's look at a sagittal section. The cerebrum is composes about 83% of the brain volume. The cerebellum contains about 50% of the neurons. Just leave it for right now. It contains 50% of the neurons with the second, and it's the second largest brain region. The diencephalon consists of the epithalamus, which includes the pineal gland, which we'll talk about, is where we get melatonin from, thalamus, and the hypothalamus. The brainstem, remember that's mostly the rhombencephalon and the mesencephalon, or the rhombencephalon and the mesencephalon. The brainstem, the midbrain, the pons, and the medulla oblongata. So cerebrum, remember that was the major amount of that was the telencephalon. The diencephalon, internal area, it's the thalamus, the epithalamus, and the hypothalamus, and the brainstem. If the telencephalon was removed from a 5-week-old embryo, which of the structures would fail to develop in the fetus? So go back and look at this. Which are going to fail to develop?
Is it A?
Why do you say that?
Was removed. By which of the following structures would fail? I just want to make sure just because that's what it eventually becomes if it doesn't fail.
Right. Tarek, you're right. It's the cerebral hemispheres. Good job. The brain is protected by some different structures. It's pretty critical. If you remember, my nervous system, damage to the nervous system, most often than not, especially the central nervous system, is not reversible. No way to recover. So the brain has a lot of protection around it. It's protected by the cranial bones and the meninges. Talked about the meninges and the spinal cord. Remember that they're continuous here with that of the spinal cord. So we have the dura mater, that tough outer covering. We have the arachnoid mater and the pia mater, which is on the surface. The meninges are continuous with the spinal meninges. So apart from the protection, they provide a structural framework for arteries and veins that service the brain. The cranial dura mater has 2 layers. It has an outer periosteal layer. It's equivalent to the periosteum of the cranial bones. Remember, that was the outer layer of the cranial of the bones. So dura mater, 2 layers, outer periosteal layer and an inner meningeal layer. It continues into the vertebral canal and forms a dura mater around the spinal cord. the layers, these two layers are separated by dural sinuses. This is going to be important later. Are separated by dural sinuses that collect blood through circulating through the brain. Unlike the spinal cord, there is no epidural space. If there's bleeding, you can create a space, but there's no a normal natural space. The bleeding can create a space, but there isn't a space before. The dura mater is going to extend into fissures and forms, be a double layer folds. The false cerebri is going to extend into the longitudinal fissure that's separating the two hemispheres. The false cerebri. This layer right here. The tentorium cerebelli is going to separate the cerebellum, this down here, from the cerebrum. And the false cerebelli is going to separate the two halves of the cerebellum. Think of tentorium as being a tent that's covering the cerebellum. The false cerebri and the false cerebelli are just separation layers, separating the two hemispheres of both the cerebrum and the cerebellum, separating the two halves. Tentorium is a covering over the cerebellum. That's the way that I tend to remember it. Meningitis is an inflammation of the meninges caused by bacterial or viral invasion of the central nervous system by way of the nose and throat. One of my students in one of my classes this semester developed meningitis last year, and she actually developed it from a salmonella infection. So that doesn't work really well here through the nose and throat, maybe, I don't know. The pia mater and arachnoid mater are the most often affected by meningitis. It can cause swelling of the brain, enlargement of the ventricles, and hemorrhaging, so breaking of blood vessels. Signs are a high fever, a stiff neck, drowsiness, and intense headache. Most easily diagnosed by examining the cerebrospinal fluid. Something that's really pretty critical here is blood supply. The brain represents about 2% of the total body weight. However, it receives about 20% of the body's blood supply. So it consumes about 20% of the oxygen and glucose, even when resting. The internal carotid arteries are going to supply the blood to the anterior portion of the brain. The vertebral arteries, if you remember when we talked about the bones, you remember that there was a little transverse foramina that was present in all of the cervical vertebrae. The reason it's present is because that's where the vertebral artery moves through. So the internal carotid artery supplies the anterior portion of the brain. The vertebral arteries supply blood to the posterior portion of the brain. Just for a second. Get a better diagram. I know you can't see my screen, so give me 1 second here. Oh, this is pretty good. So here's my common carotid artery, which is going to separate into my internal carotid artery and my external carotid artery. The vertebral artery is right here, coming up through those transverse foramina. And so both of these arteries are going to be involved in supplying the brain. So it took me to the very beginning. So the circle of Willis is a ring of arteries that's formed via an anastomosis. An anastomosis is a coming together of vessels, or an merging of vessels. To form a kind of their own little circulatory area. Merging, intertwining. Intertwining. Vessels. So this ring of arteries is formed from the internal carotid arteries and the vertebral arteries that are going to merge to form this basilar artery. And so this ring is what supplies blood to the brain, and that's called the circle of Willis. Any interruption of oxygen supply to the brain can result in weakening, permanent damage, or death to brain cells. What'd you say, Mom? Oh, don't. That isn't related to AMP, Mother. Okay. So any interruption of O2 supply. So this circle allows for alternative ways of flow if a potential blockage occurs. If a blockage occurs right here, the blood can flow this way and move that direction. If a blockage occurs here, the blood can flow this way to reach that location. While we're talking about blood vessel supply, strokes, hemorrhagic strokes occur when a weak blood vessel, which is what's called an aneurysm. You hear people who die of aneurysms. It isn't an aneurysm that kills them. It's the burst of that aneurysm that kills them. Because what it is it's a bubbling of the blood vessel. It's a weakness in the wall of the blood vessel. So the blood leaks into the brain tissue. And one thing that we'll talk about is we have what's called a blood-brain barrier. Because blood can be toxic to the brain when it gets in places it should not be. And that's what results in a hemorrhagic stroke. An ischemic or occlusive stroke, thinking hypoxia, ischemia, is the same thing as hypoxia. Same thing as hypoxia, meaning reduced oxygen supply. Reduced oxygen. So ischemic is when a blood clot flow is blocked due to a blood clot that prevents the blood from reaching an area of the brain. And whatever area that particular vessel that's blocked supplies, that tissue, that area of the brain is going to die. Well, how does the blood get back to the heart? It gets to the brain via the the internal carotid arteries and the vertebral arteries. How does it return? It returns via the dural sinuses. Remember that the dural sinuses, if you remember from several slides back, the dura mater has two layers. In between those two layers are the dural sinuses. So these are the areas where the blood is going to drain and return back to the heart via the internal jugular veins. We have a superior sagittal sinus, which is running down the longitudinal fissure, a cavernous sinus, and transverse sinus, and then a sigmoid sinus, and so forth. So it returns back to the heart via the dural sinuses that empty into the internal jugular veins. Now, like I said, the reason hemorrhagic strokes are so nasty is because blood gets to where it's not supposed to be. We have a blood-brain barrier, which is vascular endothelium around the blood-brain capillaries that forms tight junctions. Remember when we were talking about cells, chapter 3 forms tight junctions with perivascular feet of the astrocytes. Do you remember the astrocytes? They're one of the neuroglia. So they're involved in the formation of the blood-brain barrier that ensure that anything leaving the blood must pass through the cells and not between them. Things must diffuse through the cells and not in between them. So it allows for the passage of essential metabolites like oxygen and glucose, but prevents larger hydrophilic materials from the blood into the cerebrospinal fluid. So it's going to strictly regulate. It's going to seal up so that things are forced through the cells, and only things that can move through the cells are going to enter the cerebrospinal fluid. So it's going to strictly regulate what can get from the bloodstream into the blood tissue fluid. This barrier is an obstacle for delivering medications such as antibiotics and cancer drugs, because we introduce them into the blood. So trauma and inflammation, remember let me back up. The blood-brain barrier, you remember how we talked about the fact that chemotherapy, many gliomas, many brain tumors are resistant to chemotherapy because we introduce chemotherapy via the blood. And because the chemotherapy drugs can't pass the blood-brain barrier, those tumors are resistant. Trauma and inflammation can damage the blood-brain barrier and allow pathogens to enter the brain tissue. Like meningitis. So circumventricular organs are places in the brain, in the third and fourth ventricles within the brain, where the barrier is absent. We'll talk about these ventricles here in a moment, but the third and fourth ventricles, where blood has direct access to the brain. It enables the brain to monitor and respond to fluctuations in blood glucose, pH, osmolarity, and other variables. These areas, these circumventricular organs, allow for a route for invasion by the HIV virus also. Takes advantage of it. So that virus takes advantage of the fact that it can invade the brain via these circumventricular organs. It can't pass through the cells, so it passes through the brain, passes into the brain by these, using in these organs. Why is the blood-brain barrier ineffective against alcohol? And that obviously is a typo 2 when we're repeating it twice. Coming back here. skip them back. Oh, I think I went too far. Hydrophilic substances prevents the passage of larger hydrophilic substances from the blood into the cerebrospinal fluid. Alcohol is not completely hydrophilic. It borders between being hydrophobic and hydrophilic. You want to go get her? Go get her. She can't get me. Well, you're too late. Bring her back to me. Which of the following is not a true statement regarding the blood-brain barrier? Astrocytes play a primary role. It consists of many gap junctions. It prevents the passage of possible therapeutic drugs. It allows for easy passage of lipid-soluble substances. It prevents the flow of proteins across it, which is not a true statement. Someone say something. Is someone going to say something?
I'm looking.
Gap junctions. They're tight
junctions. It's the gap junctions, because remember, it's tight junctions. It's not gap junctions. So the blood-brain barrier contains many tight junctions. There aren't gap junctions. Ventricles. Remember, we saw it before. Those circumventricular organs are the third and fourth ventricles. So ventricles are cavities in the brain that are filled with central cerebrospinal fluid and keep the brain from collapsing on itself. Your brain is essentially like cold cooked oatmeal. It needs something in there to give it some buoyancy and hold it up. That's the purpose of these ventricles. So cerebrospinal fluid, remember we talked about how it's in the subarachnoid space. It's in the same space here too. So it's going to circulate through the ventricular system. We have 4 ventricles. We have two lateral ventricles. We have a third ventricle, and we have a fourth ventricle. Lateral ventricle, third ventricle, fourth ventricle. Cerebrospinal fluid is this clear, continually circulating fluid that runs through the ventricles in the brain and the spinal cord, that's constantly bathing the brain and spinal cord with oxygen, nutrients, and vital chemicals. So it's essentially working like the blood, because we don't let a lot of things pass from the blood into the brain. So the cerebrospinal fluid is performing that role. So basic functions of the cerebrospinal fluid has mechanical functions. The brain floats within the cerebrospinal fluid, and the brain is prevented from being crushed under its own weight. Remember, it's about 3 pounds, and it's got the consistency of cold oatmeal, cold cooked oatmeal. So without the cerebrospinal fluid to support it, portions of it would sink through the foramen magnum of the skull. It's a protective thing. It provides a liquid cushion that protects delicate structures from sudden movements. It transports nutrients and chemical messengers to the brain and removes waste products from the brain. It protects the nervous system tissue from chemical fluctuations that would disrupt neuronal function. And waste products and excess CSF, central cerebrospinal fluid, are going to be transported into the venous circulation and returned to the heart and the blood and heart. How is it produced? Well, it's produced from the blood plasma that leaks out of specialized blood cells called choroid plexus. It looks dark in cadavers and sheep brains. And then it gets passed through ependymal cells into the ventricles. Remember the ependymal cells? These were another form of the neuroglia. So these are the neuroglia that are involved in secreting cerebrospinal fluid that are located in the choroid plexus, which lines all the ventricles of the brain. The fluid flows continuously because of its own pressure gradient with the beating of cilia on the ependymal cells. Remember, they look like ciliated simple cuboidal epithelium, minus the fact that we don't have a basement membrane. And the rhythmic pulsations of the brain due to the heartbeat. Questions so far? So the cerebrospinal fluid is going to be returned to the blood, ultimately. It's going to be returned by a reabsorption through arachnoid villi, part of the arachnoid mater, located in the dural sinuses. You remember the dural sinuses? That's the area between the two layers of the dural mater. You have the arachnoid mater, the dural mater, which has two layers. Right in between those two layers are these little arachnoid villi that are coming out from the arachnoid mater that are reabsorbing the cerebrospinal fluid. So cerebrospinal fluid is secreted by the choroid plexus in each of the ventricles. When it's secreted from the lateral ventricles, it's going to flow through the interventricular foramina into the third ventricle. Lateral ventricles, interventricular foramina. The choroid plexus in the fourth ventricle is going to add more cerebrospinal fluid. Very highly vascularized tissue. Flows down the cerebral aqueduct into the fourth ventricle, where more cerebrospinal fluid is added. Flows out of two lateral apertures and two median apertures, openings, and fills the subarachnoid space, bathing the external surfaces of the brain and spinal cord. Here's those arachnoid villi that are moving. Here's the subarachnoid space. Here's the arachnoid mater. Protrusions of it into this space, the dural sinuses, where it gets reabsorbed. Questions? Stay with me for just a minute longer here. Hydrocephalus. What does hydrocephalus mean? Cephalus means brain. What does hydro mean?
Water on the brain.
So that's what it is. Hydrocephalus is water on the brain. What it is it's an abnormal accumulation of cerebrospinal fluid in the brain, resulting from a blockage in the route of flow or reabsorption. Can be in babies whose fontanelles have not closed. Remember, those are those little open spots in between the cranial plates. Have not closed. The head bulges due to the increased pressure. You know what? I think this is a really good place to stop. Do you have questions for me? So let's stop right here, and I will see you on Thursday.
Thank you.
You're welcome.
Thank you.
Welcome.
Hi. Professor, I just wanted to give you a heads up. I was late today because I had issues with internet. I guess there's like a national
There is,
outage.
you know, and I was almost wondering if class was going to end up not being able to happen. You're not the only one who had internet issues.
Okay. Yeah, I just wanted to, everything on the Comcast website said it was fine, but then like when I Googled it, I saw there were I guess the Bay Area was completely out for the last like
wow.
24 hours, and then Northeast went out up until like an hour ago.
Don't, Terry, I knew you were in the middle of moving, and I would be more than happy for you to come in and out of class rather than not be in class at all. Does that make sense?
Yeah. I've been trying to get in as much as I can. This
Don't
move
worry.
has been
don't worry.
An experience, to say the least.
Yeah. Don't worry. I would prefer, come late, leave early. I would prefer that more than you not coming at all. And I don't honestly notice, because people's internets go down all the time.
Okay.
And I know that. And so I'll just, when your name comes up, I just let you back in and I don't think twice about it. Okay.
Cool. Yeah. The move, it should be, I have to be out of my apartment by the 15th. So yeah. I'm not living there anymore, but there is still quite a bit to do. We decided to not get movers to save money. And then I hurt my back, and it's been it's been an experience. It's been fun.
Wow. Ouch. I'm sorry.
Oh, it's part, like I said, it's part of the experience. I'm learning, and it's a good time. I'm ready for it to be over.
It's a good time. I know. I can understand. We all love moving.
Oh yeah. Well, I will see you Thursday. Thank you so much.
You're welcome. See you Thursday.
All right. Bye.
Hi.
Hi.
I just have a quick question.
First, who am I talking with? It just comes up as iPhone 2 and I can't remember.
Michaela. I'm still trying to change my name on there and it will not change.
You're okay.
Like, it's literally impossible. But so I was wondering, because I know you said that the case study, was it open on the 9th?
The what?
The first case study?
It's open right now, and it's open through the 10th.
Through the 10th. Okay.
You know where it is?
I looked in the content, and I guess I went down to the bottom, like where it says case study.
Yep.
That's where it is?
That's where it is.
And we just answer those questions.
Yes.
Okay. And should I just like send it to you like through like a
nope, there's a Dropbox. There's a Dropbox. Bear with me just for a second here. It's a Dropbox. If you look right here under Dropbox.
Okay.
There's a box right here. You're gonna submit.
Okay.
I gotta find a nice building.
Awesome.
Yeah. Other questions?
I don't know anywhere out here.
I think that's it for me. Yeah, I think that's it for me. All right. You have a good day.
You too.
Bye-bye.
Miranda, Jamie, or Courtney, are you here?